My most humble and loving pranams at the lotus feet of our beloved Mother Sai. Sairam to all. Thank you very much for this opportunity to talk a little bit about how imaging helps in the early recognition and management of congenital heart disease. Now, throughout the day, we've heard a lot about coronary artery disease, even in patients 100 years old. So we're going to shift focus a little bit and talk about heart disease in babies and how these people grow and struggle throughout their life when they're born with congenital heart disease. In fact, congenital heart disease is the most common defect that a baby is born with, and the prevalence ranges anywhere from 7 to 9 babies per live births. A few decades ago, only 15% of babies who are born with moderate or severe complexity congenital heart disease actually survived to adulthood. But in the 1950s, with the advent of cardiopulmonary bypass, which enabled us to do extensive intracardiac repairs, but also advances in pediatric cardiology and fields of interventional cardiology. Now, over 90% of these babies survive to adulthood. And survival has improved so much that since about 2012, there are more adults worldwide living with congenital heart disease than there are children. So when we talk about prevention of heart disease, we always go and look at the cause. So if we look at the causes of congenital heart disease, they're very complex, not very well understood. We presume it to be genetic, but there are very few genes which have been shown to be linked with specific diseases. And we think it's more a combination of both genetic causes as well as environmental factors. There are very few diseases which are autosomal dominant and you can have like a 50% transmission rate. And in those diseases, there is a role of genetic counseling and prevention. But in the most part, it is hard to prevent congenital heart disease. So our focus is more on preventing and mitigating complications of congenital heart disease. Now, with all these babies living to adulthood, they struggle with a lot of complications of congenital heart disease. They have residual hemodynamic lesions, they have pulmonary hypertension, they have a lot of arrhythmias, infections, heart failure, premature death, and this is just to name a few. So one of the cornerstones then in management of these complications and management of congenital heart disease is imaging. How does imaging help in the management of congenital heart disease, and what are the goals of imaging? It helps us to detect these cardiac malformations early. You can detect cardiac malformations as early as before a baby is born when it's still in the womb, and as late as at autopsy. So at any point in a person's life, congenital heart disease can be detected, but imaging aims to detect these early. It helps assess not only the cardiac anatomy, but also physiology. It helps guide both surgical, catheter, and medical decisions in these patients. And it helps in the long-term monitoring of these patients. So what are the key imaging modalities? We have echocardiography, which we just heard some beautiful talks on. As early as fetal echocardiography, we have cross-sectional imaging, MRI and CT, and then other imaging modalities, but we'll focus on the first three, which are the key modalities for imaging congenital heart disease. So echocardiography, what are the benefits of echocardiography? We saw yesterday in the medical camp how it can be done with a tiny little device, some as small as your phone. So it's portable, it's widely available, there's expertise also worldwide. It has excellent temporal resolution. So over time, you can see, because the heart moves with every fraction of a second, you can see structures which move over time. There's no radiation. You can see small, fine structures because there's excellent spatial resolution. You can image shunts. You can look at the physiology, looking at pressure gradients. You can assess valvular pathology. But echo is limited by difficult windows, sometimes Doppler angle limitations. So there are a lot of limitations when looking at echocardiography. So then we come to MRI. The great benefit of MRI is it helps you get a lot of information non-invasively that previously you would have only been able to get by invasive catheterization. For example, you can look at multi-level valvular obstruction. You can get a lot of flow data from MRI, which you previously only got with cath. It also has no radiation exposure. It's so accurate that it's become the reference standard for assessment of ventricular volumes, mass, function. It also has this unique capability of helping characterize the tissue, which you might have only got with pathology. You can look at cardiac edema. You can look at scar formation. It helps with surgical planning because you can get 3D images. Unfortunately, though, you need a huge MRI machine. It's very time consuming. Patient has to hold their breath for several of the sequences, and it's a lot affected by metallic artifacts. So there are the cons of getting MRIs. However, CT scans, they're very rapid. They also have excellent spatial resolution like echo, so you can see small structures like we talked about coronary artery imaging. You get additional information on lung parenchyma. It is less affected by metallic artifacts, such as when you have mechanical valves. You get 3D images of a lot of the pathology. And you can get some information on volumes and function, but it's not as accurate. However, the disadvantage of CT scans, especially in a young population where you need to do sequential imaging, is that you have to give them radiation and you have to use iodinated contrast for a lot of CT scanning. So let's focus then on very early detection, fetal echocardiography. This is an example of just a regular screening ultrasound of a baby, and you can see the heartbeat. But it's amazing how much information you can get on this tiny structure of a fetal heart when you do a dedicated fetal echo. This is done at about 18 to 22 weeks of gestation. We usually perform this in patients who are at a high risk of having babies with congenital heart disease, such as a family history, maternal teratogen exposure. You can get enormous information on multiple structural abnormalities, and it helps guide delivery planning and early neonatal management. So why is it that early recognition of congenital heart disease is important? Why does it matter? Early recognition helps prevent severe complications, improve survival and quality of life, enable appropriate timing of surgery or intervention, and also helps us avoid delayed presentation with heart failure, advanced pulmonary hypertension, etc. So let's understand this a little better with a few examples. We'll take a simple form of congenital heart disease, a secundum ASD, a hole between the two atria. Many of these are small, and if they're left alone, they don't cause a lot of problems. But here I'm going to show you a patient who is 72 years old with a secundum ASD. Unfortunately, the images are not playing. Okay. So from the still image, you can see that there's a hole. So the atria are on the bottom of the screen and the ventricles are on the top. You have the right ventricle towards the top part of the screen and the left ventricle towards the bottom. You see a hole between the atria. That's the secundum ASD. The right ventricle is severely dilated. And if this was playing, you could see that there's severe tricuspid regurgitation. So this patient presented at 72 in right heart failure. This was something which could have been detected early and could have been repaired and wouldn't have developed this complication. However, now the left atrium is enlarged, the left-sided pressures are also high, and it's very difficult to close this at this stage. Let's look at another small example, another simple congenital heart disease, a patent ductus arteriosus, very easily detected by echocardiography early in life. Any sizable patent ductus arteriosus which is left alone does lead to Eisenmenger syndrome. And that will then lead to significant complications. Just to name a few, they're prone to secondary erythrocytosis. They are prone to getting brain abscesses. Sorry, none of the things are playing as they should. So they're prone to getting brain abscesses and pulmonary hemorrhage, but a lot of different multisystemic complications once they develop Eisenmenger syndrome could have been prevented with early detection of the PDA, a simple procedure either percutaneously to close the PDA or a simple procedure with surgical ligation of the PDA in infancy. Now let's look at moderate complexity congenital heart disease. We'll take one example, common example, tetralogy of Fallot. As you all know, tetralogy of Fallot is caused by a deviation of the conoventricular septum towards the pulmonary side. And this leads to 4 defects. There's the VSD, overriding aorta, pulmonary stenosis, which then leads to RVH. When we repair tetralogy of Fallot, you core out this region, usually in the RVOT or the pulmonary valve, and you close this VSD. So most of these patients are then left with severe pulmonary regurgitation. And we have one such patient here with severe pulmonary regurgitation, which also is not playing, unfortunately. Okay, so you can see from the Doppler, there's a steep angle showing how severe the pulmonary regurgitation is. Now, with patients who have severe pulmonary regurgitation, this is assessment on MRI where you can assess the regurgitation fraction. And then this is assessment of the ventricular volumes on MRI. You can see, if this were to play, which doesn't, that the right ventricle is severely dilated due to severe pulmonary regurgitation. You can see if you come down to the bottom corner that the right ventricle is the apex forming ventricle, which does mean it's significantly dilated. And when we do sequential MRIs over time, we can see how the RV changes over time and pick the right time to replace this pulmonary valve. If we replace the pulmonary valve too early, then they could require multiple pulmonary valves in their lifetime because prosthetic valves have a lifespan. And if we replace it too late, then they develop irreversible right heart failure. So we have to find the accurate timing for replacement of the pulmonary valve. Not only does imaging help us determine when that time is, but it also guides us in the management. This is that same patient. You can see the RV outflow tract in multiple dimensions, which you can then measure, and that will guide you as to whether it's possible to put a percutaneous valve in here or whether the RVOT is too large and they'd need a surgical intervention. So imaging helps us guide management too. If we look at severe complexity congenital heart disease, this is also fairly common, transposition of the great arteries, where the pulmonary artery comes off the left ventricle and the aorta comes off the right ventricle. Now, about 40 years ago, the only way to repair this would be a complex procedure, which we won't go into the details, but an atrial switch procedure redirecting the blood flow into the sides of the heart. But nowadays, since we are able to reimplant the coronaries, we do an arterial switch operation where you just take the great arteries with reimplanted. So this is an example of a patient in her early 20s, which unfortunately you can't see the perfusion imaging. But if you could have seen it, you would see that she has a circumferential perfusion defect. So a black sort of shadow around the blood pool, where you could see almost entirely circumferential around the blood pool, showing decreased perfusion to the endocardium. And then you go on to do another MRI sequence, and you can see the scar, which is also almost circumferential. This bright white outline around the blood pool is showing scar in that region, which the previous slide showed a perfusion defect. So then we went on to do further imaging to determine why this patient has this. She's presented with chest pain, and we do a CT scan, and this helps cinch the diagnosis. So you'll see anteriorly, this is the pulmonary arteries. And then if you focus on the aortic root, which are going down to see the aortic root and the coronary supply, and you will see the majority of the coronary circulation is supplied by almost a single coronary, which supplies both the right and left sides, and it's stenosed at the ostium. So she had ostial stenosis due to reimplantation of her coronaries at the time of the arterial switch. So she went on to have surgery. They found a membrane at the ostium, which they resected, and she did very well subsequently. But you can see again how imaging helps guide management. So I could go on and on with examples, but of course we're limited by time. So just to focus on imaging, it does have huge implications in the management of congenital heart disease, early detection, guiding management, and mitigating complications. We have to be cognizant, however, that there is limited access to advanced imaging in some regions, and there is a huge need for specialized pediatric and congenital cardiac imaging training, which is difficult to obtain. Looking at future directions, we had wonderful talks on AI. There's a lot of AI use in cross-sectional imaging. And also we're developing 3D modeling, so you can get actual models of the heart before you go to surgery, which helps in surgical planning. And then there's a lot of development on prenatal detection and interventions on baby, even before they are born. So while they're still in the womb, we can do certain interventions for congenital heart disease. So that's a lot of the future directions. In conclusion, imaging is central to the early recognition and management of congenital heart disease. Echo is first line, and MRI and CT are essential for complex cases and guiding management. Early diagnosis, we've seen how that improves outcomes and reduces complications. And we looked a little bit about potential future directions. Thank you, and Sairam. Take any questions. There's not much time, but yeah.
Thank you so much, ma'am, for shining a light on congenital heart disease, showing us how early detection and smart imaging can truly save young lives.